Today, I'm going to present the kidney allocation dilemma in heart transplant candidates. My name is Gaoyuan, Nephrology Fellow. The new kidney allocation policy for heart transplant candidates were implemented in last year. This picture is from UNO's website, which shows the process of organ allocation policy development. The allocation policy making is a dynamic process. We can work together to shape the policy and try to make the make the transplant system more equitable for everyone. Every year, 22,000 to 25,000 patients get a kidney transplant, while around 115,000 listed candidates are still waiting. At the same time, every year, around 4,000 to 5,000 patients died while waiting for kidneys. Around 4,000 patients were removed from the list because they became too sick. These scarce donor kidneys cannot meet the demand of kidney transplant candidates. 1% of those donor kidneys went to kidney heart transplant, which is the second most common combination of multi-organ transplant. Even though it seems only 394, but the total number of simultaneous heart kidney transplants has increased nearly sixfold from 2008 to 2023. This is the UNO's policy before 2021, which partially explained the trend. Kidneys were allocated to multi-organ transplant candidates without a renal criteria, and it prioritized SHKT candidates above candidates who only need kidneys, regardless of the extent, chronicity, or reversibility of pre-transplant kidney dysfunction. If patients' kidney dysfunction persisted after only heart transplant, they would not have such a priority and had to wait as long as general kidney transplant candidates did. In this situation, and under such a policy, when the reversibility of kidney dysfunction in heart transplant candidates were unclear, transplant folks and patients favored SHKT more over heart transplant alone. Since there was no renal criteria included in the selection for SHKT candidates, SHKT occurred regardless of pre-transplant kidney function. While there is no strong evidence to support the advantages of SHKT in candidates with high eGFR, there is a waste of precious kidneys. On the other hand, some heart transplant candidates with low eGFR did not get kidneys, so the whole status is a mess. The out-of-proportion increasing SHKT in the setting of huge disparity between available kidneys and patients on the waiting list, lack of established eligibility criteria for SHKT raises the alarm in nephrology society. Are we really sure about advantages of SHKT? Who can really benefit from that? Who deserve more priority? Is it okay to wait and give kidneys after heart transplant as an alternative? Considering equity and justice, how can we make the best use of the scarce donor kidneys? The core of kidney allocation discussion is how can we allocate the scarce kidneys in an effective, equitable, and just way? Transplant Society took action in 2019. A consensus conference on heart kidney transplant was held in Boston. Safety net policy for kidney allocation after heart transplant and the updated eligibility criteria for SHKT, including the renal criteria, was implemented last year. Today, we're going to focus on the renal criteria for SHKT and safety net policy. We're going to dig into the evidences that support the new policy, as well as the debates against it and dilemmas. As the first edition, the new renal criteria for SHKT are the same as the renal criteria for simultaneous liver kidney transplant, trying to define a maximum eGFR or minimum duration of renal injury, beyond which SHKT should not be pursued. Eligibility criteria is divided into two parts based on pre-transplant kidney function. One is for CKD patients. They would be eligible for SHKT if they are ESRD on regular hemodialysis, or if they are already on kidney waiting list and estimated creatinine clearance or eGFR is less than or equal to 30. Another part is for candidates with pre-transplant sustained AKI. If they have severe AKI, which is defined as requiring dialysis at least once every week, or eGFR less than or equal to 25 at least once a week, for at least 6 weeks, they are also eligible for SHKT. So we're going to discuss these two parts one by one. First of all, for candidates with CKD, we're going to discuss about SHKT benefits in pre-transplant dialysis-dependent and non-dialysis-dependent candidates, the optimal eGFR threshold. I bet we are all familiar with CKD's definition. Just want to emphasize that the goal of the pre-transplant evaluation of kidney function is to differentiate CKD that will not improve after heart transplant from AKI or CKD that may reverse with the hemodynamic optimization afforded by heart transplant. This is a study based on SRTR data from 2003 to 2017. It compared the outcomes in patients with SHKT and with heart transplant alone. It excluded patients with other kinds of transplant or patient got kidneys within 1 year after heart transplant. Among patients who were dialysis dependent before transplant, in SHKT group, donor heart cold ischemic times were shorter and the recipients had better pre-transplant heart function. Among these dialysis-dependent patients, SHKT group had a median survival 5 years longer than heart transplant alone group. That's a lot. This conclusion is in line with the retrospective studies using UNO's database from different time periods. So it seems clear that dialysis-dependent heart transplant candidates will benefit from SHKT. For patients who are not dialysis-dependent before transplant, we're looking for a threshold below which SHKT should be warranted. The new SHKT eligibility criteria set the cutoff of eGFR in CKD as less than or equal to 30. We're going to look into the evidences behind this standard. First of all, why do we use eGFR as the criteria? In a UNO study including 30,090 heart transplant patients, it showed that pre-transplant eGFR is independently associated with post-heart transplant mortality. This study compared the outcomes of SHKT and heart transplant alone in patients with different pre-transplant eGFR. They found in heart transplant-only recipients, pre-transplant eGFR is reversely related to the need for chronic dialysis after heart transplant. The same study showed as pre-transplant eGFR is lower, the marginal benefit in patient survival in the SHKT group is higher than heart transplant alone group. Compared to heart transplant alone group, SHKT significantly improved patient survival in pre-transplant eGFR less than 40 groups. Should we loosen the cutoff of pre-transplant eGFR to 40? Or maybe even more, expand to 45. So this recent UNO study analyzed close to 8,000 patients who had pre-transplant eGFR less than 60 and received heart transplant alone or SHKT. It excluded those who received pre-transplant dialysis. The conclusion is that in patients with pre-transplant eGFR less than 45, SHKT had a better patient survival and better cardiac allograft survival compared to heart transplant alone. But the difference looks small in the figures. For candidates who are not dialysis dependent, the advantages of SHKT compared to heart transplant alone is debatable. Debate 1, all the studies calculated eGFR based on creatinine-only equation, which could be problematic, especially when patient has cachexia, which is common in heart failure patients. This formula will overestimate eGFR. Debate 2, More importantly, eGFR is not a reliable surrogate indicator of kidney function when the patient is hemodynamically unstable, which is the usual situation for heart transplant candidates. In a position statement from the Heart Failure Association of the European Society of Cardiology, there's a concept of pseudo-worsening renal function, which means eGFR in this situation is more a reflection of intrarenal hemodynamic changes and not necessarily a signal of direct renal injury. And the eGFR itself cannot differentiate between AKI and CKD. Debate 3. Pre-transplant eGFR doesn't predict renal survival in SHKT recipients, which means regardless of your pre-transplant kidney function, patients who get new kidneys may still need chronic dialysis. Especially look at the eGFR 30 to 40 and 40 to 50 groups. There's a high percentage that they need chronic dialysis after SHKT. So maybe loosening the eGFR cutoff above 30 would be a waste of kidneys. Debate 4. The same study showed that 26% of SHKT recipients had delayed graft function. And for patients who didn't require dialysis before transplant, SHKT and heart transplant alone group had the same percentage of patients who eventually need chronic dialysis. That raises questions. Is the relative patient survival advantage of SHKT compared to heart transplant alone from the new kidneys or not? Are we wasting the kidneys? In this study, in recipients with pre-transplant eGFR less than 30 or dialysis, a total of 545 received SHKT and 80 received kidney after heart transplant. The median waiting time between heart and kidney transplant in kidney after heart transplant group was 6 years. The overall post-transplant survival had no significant difference at 1 year and 5 years between these two groups. The same result in patients with pre-transplant eGFR 30 to 44. So if it doesn't compromise the survival of recipients, why don't we wait and use the kidney after heart transplant strategy? At least that gives us a time window that we can wait for kidney recovery and avoid waste of kidneys. The second part, we're talking about the renal criteria for SHKT candidates with sustained AKI. The benefits of SHKT in this group is even more uncertain. First of all, we are uncertain about some fundamental things, how to assess kidney function in a hemodynamically unstable status, and how to predict the reversibility in these candidates if they receive heart transplant. Because we don't want to waste kidneys on candidates whose native kidney function may recover after heart transplant. We discussed that eGFR doesn't reflect real kidney function in hemodynamically unstable patients. So when we evaluate a patient's kidney function, we should also consider chronicity, trends when patient is hemodynamically optimized, comorbidities, or other findings which may indicate irreversible CKD. Even when we are sure about AKI in some patients, it's still challenging to predict the reversibility of AKI after heart transplant. It varies from patient to patient. This is a case that a patient was on dialysis for a couple months before SHKT. After 5 years, a nuclear scan showed his native kidney function recovered, which means the transplant kidney was a waste. Nuclear scan studies in simultaneous liver kidney recipients have demonstrated that varying degrees of native kidney recovery in up to 50% of recipients. But the extent of native kidney recovery in simultaneous heart kidney transplant is unknown. In the era of critical organ scarcity, unnecessary kidney transplants should be viewed as an adverse outcome as much as patient death or graft failure. Regarding this eligibility criteria, we have seen that the evidences are conflicting and debatable. But again, this is just a start. After we gather more data after the new policy implementation, we can further revise the criteria and policies. The new policy still prioritizes SHKT candidates in kidney allocation above kidney alone candidates. Well, there are over 100,000 patients waiting for kidney-only transplant, and most of them will have significantly improved life expectancy and life quality from kidney transplant. We're giving kidneys to candidates whose kidney dysfunction may recover and for whom kidney transplants may be a waste. Is that really a wise decision? SHKT candidates, they have the priority in kidney allocation is not based on strong clinical evidence, more likely due to the policy, which can be considered as a systemic bias. Simultaneous kidney transplant for these heart transplant individuals may be beneficial or no harm, but given the scarcity of donor kidneys, we should think about it in a bigger picture. Need to weigh the magnitude of the benefits to SHKT recipients against the benefit that the kidney would provide for kidney-alone candidates. We should allocate kidneys in a way that we can maximize the survival benefit from each kidney on a system-wide level. To maximize the survival benefit of each kidney means we're trying to allocate it in a way that it can generate the most quality-adjusted life year gain at the least kidney cost. Stanford developed a model to make the cost-effective analysis in heart transplant patients. It sounds a little cruel, but it's what we have to do given the scarcity of donor kidneys. They found for age 50 to 59 candidates with high reversibility after heart transplant, SHKT is inefficient because it produces fewer quality-adjusted life year gain per deceased donor kidney than a deceased donor kidney allocated for kidney transplant alone. In that scenario, we should give the kidneys to patients who only need kidneys. This is an exciting study, but it's based on some simplifying assumptions and cannot reflect the real world. In reality, it's still hard to assess the reversibility of kidney injury. In this recent study, over 1,000 donors who donated the heart and simultaneously donated one kidney to one recipient. 97% donated the contralateral kidney to another recipient. The 1 year and 5 year cumulative incidence of kidney allograft loss in SHKT group is significantly higher than the kidney transplant alone group. Are we wasting kidneys by doing SHKT? If we can better predict kidney function after heart transplant and have better selection criteria, we can decrease the renal allograft loss in SHKT recipients. We've talked about evidences and debates about SHKT. In summary, compared to heart transplant alone, SHKT improves long-term patient survival in certain groups, may improve cardiac allograft survival, which is still questionable. The disadvantages of SHKT compared to heart transplant alone included potential kidney waste due to reversible native kidney function after transplant, kidney allograft function loss, or patient death with functioning grafts. SHKT also results in possible inequity for kidney transplant alone candidates. But we're not saying that we should ban heart transplant candidates from receiving kidney transplant. We're just seeking better selection criteria for SHKT and shifting the timing of kidney transplant downstream from the time of heart transplant, while not compromising the survival of heart transplant. That's why we developed safety net policy. In section 2, we're going to talk about the benefits of safety net policy in different groups. For patients who are excluded from the eligibility criteria for SHKT, don't panic. You still have 1 year warranty to maintain the priority to get a new kidney as long as you meet the safety net criteria. Since it's tough to predict the reversibility of kidney dysfunction after heart transplant, safety net policy takes some of the pressure off. If patients are listed for kidney transplant within 1 year after heart transplant, or if they have persistent severe kidney dysfunction during 60 days to 1 year after heart transplant, they will have the priority to get kidney transplant. These patients are either on dialysis or on the edge of needing dialysis. They are prioritized above general kidney transplant candidates, except those who are highly sensitized, medically urgent, no mismatches for HLA-ABDR. We will see how many kidney transplants will happen within 1 year warranty under safety net policy. This is the largest study to date about post-heart transplant AKI. It found that the incidence of AKI on dialysis after heart transplant increased from 7.9% in 2009 to 13.9% in 2020. Compared to patients who didn't need dialysis right after heart transplant recipients on dialysis immediately after transplant had a 7-fold increased risk of 30-day and 1-year mortality and an increased risk of rejection by 1 year. That supports the time window of 1 year mentioned in safety net, but whether kidney transplant in AKI on dialysis patients within 1 year after heart transplant will change outcomes, and how long should we wait, still need further studies. This retrospective single-center study included 121 heart transplant recipients who developed ESRD after heart transplant. It divided them into 3 groups: kidney transplant, dialysis, conservative treatment group. It showed that kidney transplant significantly improved the patient's survival compared to other groups. The same study that I showed earlier as evidence against SHKT is a supporting evidence for safety net policy. And even better, this evidence indicated that we can wait for more than 1 year. So whether the 1 year kidney transplant priority is necessary is still a question. In summary, why do we need safety net? Post-heart transplant AKI dialysis increased 1 year mortality and the risk of subsequent ESRD on hemodialysis. Kidney after heart transplant improves patient survival for patients with post-heart transplant ESRD. For heart transplant candidates with pre-transplant kidney dysfunction, kidney after heart transplant has comparable patient survival compared to SHKT. So safety net can avoid unnecessary SHKT and increase the deceased kidney donor pool. This is the take-home message today. The current kidney allocation process in heart transplant candidates for patients with pre-transplant kidney dysfunction, if they meet SHKT eligibility criteria, they can get SHKT. If not, they get heart transplant only. But there's still a 1 year priority warranty. See whether they meet safety net criteria within 1 year after heart transplant. If they do, they get kidneys much faster than general kidney transplant candidates. If no, they have to wait as other kidney transplant candidates do, which is not the end of the world, because it's possible that waiting for 4 to 6 years with kidney dysfunction would not affect the survival. There's still a lot of work to do regarding the dilemmas and debates. We can make the policy better. I appreciate the sincere help from our great nephrologists, Dr. Yin and Dr. Benzo. They supported and guided me for this presentation. Thank you.
Thank you, Gaoyuan. Wonderful presentation of a clinically and ethically complex issue. Questions for Gaoyuan?
I have a question and a comment. Gaoyuan, that was just an outstanding presentation. Truly, you really not only showed the data that's out there, but also presented the important policy questions. With the HRSA modernization initiative, which was really bicameral and bipartisan passed, and as long as they can find appropriations this year or next, there's going to be a lot of change in the transplant sphere, but they haven't really looked at allocation issues with regards to, dual organs. So I wonder if you're thinking about dual possibilities, where would you focus? Would you focus specifically on trying to talk about avoiding transplanting an acute kidney injury? Would you think about advocating for transplant post heart, kidney transplant post as opposed to peri? I just thought that this was a great presentation. It opened my eyes to a lot of things. So curious what you think.
Well, I would say what I can expect is like the experience so far we got from simultaneous liver kidney transplant after the safety net policy for kidney allocation in liver transplant candidates. It found that after that policy implementation, the total numbers of simultaneous liver kidney transplant kind of stabilized, not really like decreased, but at least stabilized. And I would say, just as I said, like not really ban them from getting like dual organ transplant, but like avoid unnecessary simultaneous like transplant. It's like even though for some group for some subgroup of patients, they at the end they still get another kidney, so on top of the heart, but at least they wait for years, so it's not like a priority. So during that time, it's still like expanding, more expanding pool than before. I would advocate for not like do less simultaneous dual organ transplant because it sounds kind of unfair for patients who only need kidney.
Thanks.
Thank you.
I think this discussion is really interesting when there's a crosstalk between two allocation systems that are ultimately based on kind of different principles. The kidney allocation system, what FAIR is mostly a wait list, mostly putting in your time. And what FAIR is for heart transplants has a lot more to do with urgency for people who are otherwise approaching end of life. So finding kind of common outcomes that we agree on, and as you've done, comparing numbers of survival and things is seems like the right way, but just recognizing there's a lot more complexity in just how we think about what's fair in those two systems. Leah?
Yeah, I can easily imagine being a heart transplant recipient with, a GFR that doesn't quite get me into the safety net, and, being on tacrolimus and watching my creatinines go in and out of the safety net. And kind of wanting my kidney function to get worse enough in the first year. How is that managed? How do you manage someone like that from the transplant folks? So, when the patient's wanting their kidney numbers to get worse so that they fall into the safety net, whereas you're trying to preserve their kidney function, how do you manage that balance? So,
I think for this question, I need some help because
I'm
haven't
asking
rotated in
the transplant
yet.
doctors.
Maybe I can say something. Yeah, you're absolutely right, Leah. Like we've had a few patients where their eGFR is like 22, and we're sitting there saying, okay, should we put the ACE inhibitor on board or the SGLT2 just so that we can tip them over at that 360 days? They have 5 more days. We need to hit them. But I think the other thing is, Gaoyuan makes a very good point, right? So yes, they'll get that kidney transplant, but the outcome if they wait a little bit longer. So if these patients can last another 3 years, because at 22 you can put them on the list, they just won't get the priority, right? So if these patients can last another 3 years until the regular wait time, that's not necessarily a bad thing either. At least we don't whack them with more immunosuppressant within that 1 year. So it's not I suppose it's not necessarily a bad thing that they have an eGFR of 28.
Right. How,
We don't usually think so. Well, thank you. Thank you for excellent discussion. Great presentation.